Dear viewers, the use of albumin is common in hospitalized setting for various reasons. Here in this video we will discuss evidence-based indications of albumin use. I am Dr. Sunil Garg from Essentials of Acute Care. Despite the theoretical advantage of albumin over crystalloids in maintaining oncotic pressure, multiple randomized controlled trial and meta-analysis have reported that albumin infusion did not improve either short-term or the long-term mortality in septic patients. But it can be given to sepsis and septic shock patient if patient has already received substantial amount of crystalloids and likely more fluid is required as response to crystalloid is suboptimal, with the understanding that it is not going to provide outcome benefit in terms of mortality. The total amount of fluid infused will be reduced. The use of albumin in hepatorenal syndrome is evidence-based. It is helpful both in the diagnosis and treatment of HRS. For the diagnosis of HRS, albumin is given 1 gram per kg of body weight per day up to a maximum of 100 gram per day for at least 2 days, along with withdrawal of diuretic if it is going on. In terms of treatment of type 1 HRS, administration of both vasoconstrictors like terlipressin and albumin 20 to 40 gram per day is recommended. For type 2 HRS, the use of albumin is controversial. Another evidence-based indication is in post-paracentesis circulatory dysfunction. This is circulatory dysfunction occurring after the large volume paracentesis. It is characterized by an exacerbation of arteriolar vasodilation, reduction of effective blood volume, rapid reaccumulation of ascites, increased risk of HRS, dilutional hyponatremia, and increased mortality. Albumin is given in such patients 6 to 8 gram per liter of ascites removed with a greater strength of recommendation for paracentesis of at least 5 liter. Another evidence-based recommendation is its use in prevention of renal failure in patients with spontaneous bacterial peritonitis, where it is given along with broad-spectrum antibiotic in a dose of 1.5 gram per kg on day 1 and 1 gram per kg on day 3. Now we will know when albumin should not be used. Serum albumin concentration should not be a guide for albumin use, hence there is no evidence-based recommendation of its use in patients with hypoalbuminemia due to any cause including cirrhosis and nephrotic syndrome. It should not be given for nutritional intervention and it is contraindicated in patients with the traumatic brain injury. So to summarize, evidence-based use of albumin, it should be given for patients with HRS, both for diagnosis of HRS and treatment of type 1 HRS, for post-paracentesis circulatory dysfunction in cirrhotic patient, for prevention of renal failure in spontaneous bacterial peritonitis. It can be given to sepsis and septic shock patients if they do not respond adequately to crystalloids, even after receiving substantial amount with the understanding that it does not provide any mortality benefit. It should not be given for the treatment of hypoalbuminemia due to any cause or for nutritional interventions. And it is contraindicated in patients with traumatic brain injury. Here I finish. Thanks for watching this video. Please do not forget to click the subscribe icon. See you again with my next video on some very interesting and controversial topic in critical care medicine. Till then, bye.